injury that is common in high school men's basketball is the lateral ankle sprain. The lateral ankle sprain is a partial or complete stretching or tearing of the anterior talofibular ligament when the ankle rolls in an inverted direction. This type of sprain is the most common of sprains. Common mechanisms of injury includes the inversion of a plantar flexed foot, which causes damage to the lateral ligaments of the ankle. This can occur from rapid shifts of the body's center of mass, of overlanding or of the weight-bearing foot, or a quick change of direction. This information comes from Physiopedia. The bones that make up the ankle joint are the distal tibia and fibula and the medial and lateral malleolus, respectively, along with the talus. The joint is called the talocrucial joint. It's a hinge joint between the inferior and superior surface of the tibia and the talus. This joint allows for plantar flexion and dorsiflexion. Because plantar flexion is the most unstable position within this joint, it explains why it is such a common injury to have a lateral ankle sprain within the plantar flexion. The ligaments that are involved in the lateral ankle sprain include the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. Muscles involved with moving the ankle are from the calf, which is the gastrocnemius and the soleus, the peronei, and the tibialis anterior. In order to assess this injury, you want to watch the patient as soon as they walk in the room, how they're walking, their gait pattern, how much they're limping, if that's applicable, their facial expressions when they're weight bearing on the injured leg, on the injured ankle, and any other signs of discomfort that they may have. You want to take their history of what had happened and record if this is a reoccurring injury or if this is a first time. If it's a reoccurring, you want to give a scale of 1 to 10 of how bad this injury is compared to the others. Range of motion needs to be assessed. This includes plantar flexion, dorsiflexion, inversion, and eversion, and resisted strength of eversion. You want to be able to palpate the lateral aspect of the ankle, searching if there's any tear. And all this information comes from Physiopedia. The next injury we have is a jam finger. Jam fingers are not fun. This is when there is a force of impact on the tip of a finger. It's often from a ball or a wall, or in sports, in basketball, it's most often from a ball. A jam finger is when the tip of a finger is pushed back into the hand. Due to the momentum, the tip of the finger isn't necessarily injured, but it's the joint that is taking all the impact, and that is the proximal interphalangeal joint. This information comes from eMedicine. This is a pretty common injury in basketball, and it is a simplistic injury when it's just revolving a jam finger and not anything more of a break or anything. So the common mechanisms of the injury is when the tip of an extended finger comes in contact with a blunt force, which is often from a ball. It's from catching something or running. I've gotten a jam finger from running into a person on the court, not necessarily from the ball, but it's when a direct force impact comes in contact with the tip of an extended finger. The bones involved with the jam finger are the phalangeal bones, specifically the interphalangeal joint. That's what takes most of the blow when the tip of the finger comes in contact with a blunt force. The ligaments that are often stretched or torn are the collateral ligaments within the finger. In order to assess this, you want to understand how the injury occurred, the history of the injury. You want to check the position of the fingers, movement, swelling, and pain. More often than not, you want to take x-rays just to rule out a break. Jam fingers can be treated pretty simply with the Rice method. You can buddy tape it or splint the finger in order to keep it from bending in a certain direction and keeping it safe and comfortable. But continual use of the Rice method will drastically help the jam finger. This information comes from eMedicine. An ACL tear is an anterior cruciate ligament tear. It is a very common tear in the sport realm. It's often known as a plant and twist injury, and it often happens with no contact rather than with contact. It doesn't need a blunt force to happen. The tearing of the ligaments creates an unstable knee joint, and most ACL tears are complete or almost complete tears. And this information comes from Sports Injury Clinic. The mechanisms of this injury are often, like I said before, plant and cut or twist injuries are not often from a direct blow. The anterior cruciate ligament can be injured, however, in a variety of ways, from rapid change of direction, sudden stopping, slowing down while you're running with that pressure, landing improperly, or, in rare cases, direct contact/collision. The ACL tear is commonly known as the plant and twist injury because that is the motion that it often occurs in. ACL tears involve the separation of the anterior cruciate ligament from the upper and lower legs, which are the femur and the tibia. In order to have assessment of this, you want to watch them walking in the door if they are weight-bearing. Depending on how painful it is, their facial expression, it's pretty much the same assessment that goes along with the lateral ankle sprain, all in regards of just not touching them, but simply observing how they are handling the pain. It's important to assess how active they are, how this injury occurred, and it's important to do this just based on how you're going to go about treating and if surgery is necessary or if they can go ahead and go with a physical therapy route, depending just how active they are. It's important to assess all the structures within the knee. More often than not, when an ACL injury occurs, more than just the ACL is injured, so you want to be able to rule out other concurrent injuries, and this type of assessment should be only carried out by a doctor or professional therapist. Some tests that you can assess on the scene would be anterior draw test or the Lachman's test. They're very similar in the sense that the anterior draw test, the patient lies on their back, the knee is bent at 90 degrees with the foot flat on the table. The assessor grasps the upper tibia with both hands and pulls forward. And if the tibia moves forward, then you know that it's a positive result, and therefore the ligament, the anterior cruciate ligament, is torn or completely torn or partially torn. Because everyone has different ranges of motions and knees can be tricky, you want to do that on the opposite side as well, just to see if the movement that occurred on the injury knee is as far an extent with the opposite knee, or if they have really loose joints, or if it's actually completely or partially torn. So you want to do this on both sides, on the injured knee and the non-injured knee, just to get their baseline. You can also perform the Lachman's test. This is similar, where the patient lies on their back with the knee flexed between 15 and 30 degrees. The assessor grasps the lower outside of the femur with one hand and the inside of the upper tibia with the other. Having the femur stabilized, you pull the tibia forward, and if the tibia moves excessively forward, then you know that the test is positive. After these tests occur and further assessment, you can more often than not, you will have an MRI scan or x-rays to explain and confirm all the diagnoses that have taken place, and all this information comes from Sports Injury Clinic.